name is Jozelynn Worden. I am a neonatal nurse practitioner at the University of Michigan Children's Hospital. I've currently worked here for about 3.5 years, and I am also a DNP student at the University of South Alabama. I'm here today to present to you my DNP Quality Improvement Project, which is called Decreasing UVC Migration to Improve Neonatal Outcomes. So, I wanted to start off with an introductory of what an actual UVC is. A UVC is inserted through the umbilicus in a neonatal intensive care unit, and this is one of the most common procedures that we may perform. This line can be used for several different things. It can be used for intravenous fluids, total parental nutrition, exchange transfusions, medications, lab draws, and even as an emergency in a delivery for resuscitation. This procedure I wanted to mention is not benign, and there can be many complications if migration occurs and goes unnoticed. So, why do we care as advanced practice providers? We care because we want to be providing the highest quality of care with the best evidence to all of our patients so we can improve the outcomes. So moving into a little background of the UVC, we currently use the Shukla method at our university, which is the birth weight times 3 plus 9 divided by 2 plus 1. That is a mouthful, I know. And as we have been doing this for so long, the research has actually been starting to show that this leads to overinsertion of the UVC, and they suggested removing the plus 1. That is now the Shukla method. I have a diagram over here that I wanted to show you guys as to where the UVC actually goes through. So it goes through the umbilical stump, through the ductus venosus, through the portal vein, and into the inferior vena cava over here, and in the right atrial junction. On x-ray, you'll see that that is between T8 and 10. That is evidence-based. Once in place, you'll secure the UVC with a purse string suture per the neonatal handbook. That is the gold standard, and also an adhesive of the current NICU's choice. We currently use the umbilical bridge at our institution. Several researchers have noticed that this line does not stay in place and that complications have resulted from this line. The most common research that I had found was that 25% of UVCs do migrate within that first 24 hours after placing, despite having proper position at starting. The umbilical stump does change after an infant is born. It does get shorter, so there are fluctuations in abdominal circumference, and regular use of the catheter also contributes to that migration, either abnormal or normal. And more researchers found that 20% of their UVC complications were related to, in fact, malposition. Some of these complications include pleural effusions, pericardial effusions, liver injuries, and thus can lead to chronic issues for these children. For example, there are unnecessary liver biopsies that have been performed for little calcifications on the liver, which leads to unnecessary treatments and procedures in these poor children. And finally, the CDC does recommend removing the UVC by 14 days. This was calculated based on sepsis, not UVC complications. Moving forward, I wanted to identify the reason why we needed a change in our UVC care in regards to migration, because a couple years ago we experienced a severe adverse event where a patient had the UVC placed, was migrating into the right atrium, caused a cardiac pleural effusion, which led to cardiac tamponade and arrhythmia, and led to multiple unnecessary medications, procedures, and consults with the cardiology team. This event could have been definitely avoided in many ways if we had done things differently. So, since we have not had a change following this event, we as a unit believe that we need to make a change. So the purpose of my project is to evaluate the effectiveness of a UVC bundle to improve patient safety by decreasing the percentage of inadvertent migration for all inborn neonates of any gestational age that required this type of procedure. Specific aims, in which I'll get into on the next slide, focus on standardizing the care of the UVC by implementing a bundle from the literature that aim to reduce patient harm caused from UVC. And right now, the literature does not give consistent guidance on UVC care, so we used the evidence that fit our unit best. So the current aims of this project, which I will get into more specifically in the following slides, include using a hold-a-line. Like I said, currently we use an umbilical bridge, so we wanted to change our device and go to a hold-a-line plus the suture. Next, we wanted to standardize care by obtaining x-rays at the same time intervals after placing. Then we wanted to drop the percentage of UVCs left in greater than 14 days to reduce that risk of sepsis. Next, we wanted to reduce the number of serious complications, like the one stated previously, from UVC migrations. We wanted to lessen the number of UVCs dislodged completely, which normally occur during transfer of the patient to parent holding. And decrease the amount of UVCs discontinued early due to malposition. So outside of that range of T8 to 10, which is normally in the liver at that point if it's outside that range of T8 to 10. Because if it's above T8, we can always pull it back, but malposition is when you actually are below T10. So methods for this project include the setting, which is a 59 bed level 4 NICU at a children's hospital in Michigan. 100 patients were included in this project. 46 were pre-implementation in the chart review that I completed, trying to figure out exactly where we needed to fix the problem. And post-implementation included 54 patients, 10 in which that were excluded due to transfer to another unit. Stakeholders were extremely important in this project, and those included were patients, nurses, clinical nurse specialists, advanced practice providers, and physicians. Finally, it was important to obtain IRB approval from both University of Michigan and the University of South Alabama. My project ended up being IRB exempt given that there was no new research being performed and this was a quality improvement project. So moving forward to the interventions. First, there was a retrospective chart review of 50 random patients in 2020 that had a UVC in place. Data collected on these patients included gestational age, weight, diagnosis, gender, migration data, timing of the UVC removal, complications that occurred from the UVC, adverse events from the UVC, timing of x-rays at that time while the UVC was in place, and if the line was discontinued early due to malposition. So from this information, I was creating a survey to send to staff because I wanted to get their perceptions on what they thought the current UVC problem was and why it was occurring and what we could do to fix it. So from the survey information that 188 respondents did reply, the majority said that we had a problem with first the umbilical bridge, which they were not very fond of because they did not believe that this secured the UVC for all patients. I have a picture of the umbilical bridge here. They believed that a lot of the infants could stick their hands in between the umbilicus and where the tape comes off of the patient, and or sometimes loop their fingers in the line itself. The other problem they thought we lacked was education for parents when transferring, and that the providers thought we didn't get enough surveillance films because there wasn't any set time for surveillance films. Only x-rays were obtained when clinically needed on the patient. So with that being all in, with that information all being said, I took the retrospective chart review and the surveys and the literature, and we created a customized UVC. We implemented from the literature a UVC bundle customized to our specific unit. And this included the calculation depth, that revised Shukla method that we talked about in the first slide, also the appropriate position that the UVC needed to be in after placement between T8 and T10, preferably right at T8. The timing of our repeat x-rays, which would be between 24 to 36 hours from the literature, and every 7 days as the line was in place. We were going to use the hold-a-line as the new securing method, given that staff were very unhappy with the umbilical bridge. And we were going to leave our lines in for 14 days or less, because that was according to the CDC's recommendation. So, moving forward to education, first I needed to present my project to joint practice. After joint practice approved my project, I was able to move forward and present to the staff on the unit. Joint practice is in place to ensure policies and procedures remain current to the latest standards of practice. So they're there to make sure that what we're doing is safe for the patients. Then my email that I sent to all staff members, all stakeholders, explained the UVC bundle. I showed a video on what to do with the hold-a-line, how to put on the hold-a-line, and also how to remove the hold-a-line, and also the project's timeline. And then also in-person education was done upon request. There was a very large number of nurses, so I wasn't able to reach all of them in this short time this QI project was conducted. Finally, nurse and APP champions were identified to help me relay information between what they were currently doing in practice and between the researcher. So that way I could improve on any problems that needed to be done. So during implementation, this was a 3-month period from June to September of 2021, there was daily data collections of where the UVC was and if nurses had made any implications that the hold-a-line was having issues sticking, or if they were having issues with their families during transfers and things like that. Other information that was collected in these chart reviews was very similar to the previous. So birth weight, gestational age, the gender, diagnosis, number of days UVC was in place, timing of migration if it occurred, adverse events, complications with the hold-a-line, if there was accidental dislodgements, and if there was an early discontinuation of the UVC due to malposition. Next, we always had weekly in-person or email communications with the APPs that were the champions and the nurses that were the champions. Also, the clinical nurse specialist and my preceptor help make this project better, because I always was looking for ways to improve the project to make it go more smoothly. Finally, after the project was complete, a survey was emailed to all staff that were involved, asking how the hold-a-line was with the UVC and migration, and also how effective the x-rays were at finding migration timings. So here is just directions on how to apply the hold-a-line and remove the hold-a-line. Data analysis included pre and post were descriptive statistics. I found the percentage of gender, diagnosis, and timing of UVCs that were discontinued due to malposition. I also calculated the migration direction, inwards, outwards, or no. Also calculated the standard deviation for gestational age and birth weight. So moving on, we calculated independent sample t-test to compare UVC length of time and timing of migration pre and post. All of my data was put into Excel using an alpha set to 0.05. Unfortunately, my UVC bundle that was implemented from the literature did not lower rates of inadvertent migration, nor did it decrease the number of lines that were discontinued early due to malposition when compared from pre-implementation to post-implementation. The one good thing that I did find when comparing lines that were discontinued early was that we were able to identify lines that were malpositioned sooner post-implementation than pre-implementation. We were able to discontinue all of those malpositioned lines by 72 hours, whereas before it was anywhere from 72 to 168 hours. So that's a long time for that UVC to sit in a malposition and cause potential liver damage or clots or effusions of some kind. Next, there was no serious adverse events that were noted during implementation. Pre-implementation, there were 2 heart arrhythmias that were noticed because the UVC was in the right atrium. Both of these babies did not receive any extra medications, but their UVC was discontinued early due to SVT, and cardiology was consulted. But after both lines were removed, SVT did not occur again. Unfortunately, one UVC was discontinued during project implementation, even with the hold-a-line and the suture in place during parent transfer. Also, pre-implementation, UVCs were found to have migrated around that 48-hour mark, or post-implementation, we found that it was more common to see them migrate in the first 24 hours. I suspect that this is related to us getting x-rays in that 24 to 36-hour time frame, whereas before we didn't have that, so we were seeing the migration at a later time because that's when we were getting the x-rays randomly. And then the average number of catheter days that were in pre and post was about the same, in which I'll show you my results on the following slide, but it was about 5 days average. And the number of lines that remained greater than 14 days was about the same both pre and post, which I'll show you on the next slide. And finally, staff surveys revealed that they really enjoyed this new method of taping with the hold-a-line. They preferred it over the umbilical bridge, but there still was a lot of issues identified with the hold the line in terms of sticking on dry skin. Also, that the umbilical venous catheter would slip out of the hold the line if not secured properly, and also that it did not stick very well during transfer to patients. Of course, it fell out when they were transferring one baby. So unfortunately, we did have that. Here is my data tables. So you can see the gestational age pre and post did not change and the value was not significant. Birth weight, also the value was found not to be significant. It was about the same pre and post. Gender-wise was also not significant. It was almost 50-50 female and male in pre and post. And the diagnosis, the majority was prematurity, pre and post, but we did also have surgical and other in there. So my next table shows hours of life UVC migration occurred. And the most interesting finding with this table is that 18% of UVCs went unknown if migration ever occurred pre-implementation, and that is because there was no follow-up films to follow that migration. And in post-implementation, we had 0 that were unknown. Next, the direction of migration is the table that I have. You can see that pre and post implementation, the majority of our migrations occurred were outward, and still in the pre-implementation, 22% were unknown. Finally, number of days UVC is in place is my last slide, and I kind of already mentioned it before that we had greater than 14 days, 2% pre, and greater than 14 days, 4% post. I think that little bump in percentage is probably related to patient acuity because we do not remove UVCs in highly acute patients that could not undergo PICC procedures. So, moving on, conclusions. So, implementation of this UVC bundle did not guarantee that migration would not occur in the UVC. So, what it does provide is standardization of care and awareness that migration is normal for a UVC, but it becomes a problem when it becomes abnormal outside of those areas to T8 to 10, and it can cause harm to patients. So by standardizing the care, we can improve patient outcomes. Finally, communication, education, and stakeholder participation were all extremely important in the success of this study. Future recommendations are for this for further quality improvement projects could focus on potential other types of securing methods that may lead to potential decrease in UVC migration because the hold the line was not found to decrease the migration. For example, standardizing suturing technique. Also, researchers could determine if there is a better modality to find these UVC positions rather than x-rays to save radiation to these infants. And here's my references. I have completed my DNP project. If you have any questions, please let me know. I can leave my contact information on the last slide. Thank you so much for listening and have a great rest of your day.